औज़ुबिल्लाहि मिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम अर्रहमान अल्लमल कुरान खलक़ल इंसान अल्लमहुल बयान। आज काफ़ी दिन के बाद आप लोगों से बात करने का मौका मिला है और इसकी वजह कोई एकेडमिक मसरूफियात थी जिसकी वजह से मैं कुछ नया रिकॉर्ड नहीं कर सका। आज शुरू करते हैं आज की अच्छी बात से। फेलियर, याद रखिए, फेलियर ऑपोजिट ऑफ सक्सेस, इट्स पार्ट ऑफ द सक्सेस। जिस प्रोफेशन में हम आ चुके हैं इस प्रोफेशनल लाइफ के अंदर, इसमें याद रखें इज़ नथिंग फेलियर, यू नीड टू वर्क हार्ड और इस चीज़ की परेशानी नहीं लेनी। आज के सिलसिले का हमारा टॉपिक है लार्ज हेड। तो लार्ज हेड में आपको कमांड दी जा सकती है, दिस चाइल्ड इज़ हैविंग लार्ज हेड, प्लीज़ एग्जामिन, और ये आपको कमांड ये भी दी जा सकती है, टू द जीपी एंड रेलिवेंट। So like all short cases, you start with the introduction, consent, exposure, hand sanitization. Then you go for inspection. In that you go see whether the child is sick or well. Is there any cyanosis, respiratory distress at rest? Is there any pallor or jaundice? What is the nutritional status of the child? Is there any diagnostic or dysmorphic features, such as hemolytic anemia, such as thalassemia, thalassaemic facies, or dysmorphism such as Soter syndrome, MPS, which we have large head, interventions such as oxygen, NG tube, cannula. If the command is GP, start from the hands. Hands you see for the chylonychia, clubbing, then you go for the wrist, you check for the widening for the vitamin D deficiency, pulse, check the respiratory rate, then the BCG scar, and the head size. You measure the head size 3 times, taking into the 3 prominences and record the largest measurement. Then you do the apologies for a little pause. Then you check the height and weight. After that, go to the head. First, you measure the head circumference 3 times, like I said, and record the maximum reading. Then look for the shiny scalp and prominent scalp veins. Make the child sit with support. Palpate for sutures, anterior fontanelle, trace VP shunt bulb, crackpot sign, split sutures, and absent anterior fontanelle pulsations, sign of hydrocephalus. Then you see the shape of the skull. If there is a frontal prominence, there is a sign of obstructive hydrocephalus. If there is a parietal prominence, there can be subdural fluid or porencephalic cyst. There is occipital protrusion, it is due to the Dandy-Walker cyst. In the small posterior fossa, there is aqueduct stenosis. Inspect spine for meningomyelocele. Sorry for the spelling mistake. Inspect spine for meningomyelocele, swelling, scar of repair, or the tuft of hair. Then you measure the length or height. It is low in achondroplasia, increase in Soto's motor system. You just perform the complete upper and lower limb examination. Hemiplegia with hydrocephalus, post-meningitic sequelae, subdural hematoma. Then you examine the upper limb versus lower limb, because in lower limb spina bifida is the cause. If the child is old enough, you check for the gait and cerebellar signs, that is due to Dandy-Walker signs. Then you check the eyes for the sunset sign, cataract, squint, check for extraocular movements. Then you check the chest for the signs of rickets. Then go for the abdomen, check for the scar of VP shunt, liver and spleen, bladder palpate. Also check the spine at this time. Anus, patulous anus, you must ask the examiner before doing this. Then you screen the skin for the neurocutaneous stigmata, for the tuberous sclerosis and neurofibromatosis. Now for the hypothetical description. I have examined 10 months old Junaid, who is sick looking, undernourished child without obvious respiratory distress and cyanosis at rest, and there are no diagnostic or dysmorphic facies. He has markedly enlarged head size with OFC of 49 cm. The scalp skin is shiny with prominent veins. The anterior fontanelle is tense and wide open with bulb of VP shunt palpable and is functional. There is a scar mark in the lumbosacral region of spine. The lower limbs are hypotonic with absent reflexes and power was about 2.5. The upper limb examination was normal. The length of the child is 70 cm and weight is 10 kg. I want to plot them on the centile charts. There is a sunset sign without cataract in the eyes. There is a scar mark of VP shunt in abdomen. There is no pallor cyanosis, signs of rickets, hepatosplenomegaly, palpable bladder, and patulous anus. There was no neurocutaneous stigmata. My clinical findings are consistent with the diagnosis of hydrocephalus with VP shunt, which is functional. Diagnosis of hydrocephalus it can be caused by the communicating or non-communicating causes. In communicating causes include the meningitis, toxoplasmosis. Non-communicating causes are such as obstructive aqueductal stenosis, Dandy-Walker malformation, Arnold-Chiari malformation, holoprosencephaly, porencephalic cyst. Then the investigations, ultrasound of the cranium, CT scan of the brain or MRI brain. Plain X-ray film will show us the increased convolutions such as the silver beaten appearance, increased separation of sutures and erosion of the posterior clinoid. The treatment is ventriculoperitoneal shunting or endoscopic third ventriculostomy. It doesn't require repeated shunting. Meningomyelocele treatment is the surgery. If CSF leak is there, then it's urgent, otherwise a few days after the birth. Complication of the repair is hydrocephalus. Look for other anomalies like clubfoot, other renal anomalies. These are associated with this, such as the neurogenic bladder. Then you have to teach the child with the bladder or bowel training. For that, clean intermittent catheterization because these children having neurogenic bladder, and if you do not give this intermittent catheterization, it can lead to CKD. Then use the latex-free catheter in gloves. Perform the periodic RFTs. Perform urinary and CS. An MCG is required to rule out the secondary VUR. Then artificial sphincter implantation is there. And timed enemas are given for rectal disinfection because these child can have constipation. Ambulation aids are needed and braces are also required by these children. Few words on prevention. The 0.4 milligram folic acid is given to all women 1 month before contraception. 1 month before conception and 4 milligram in high risk. There is a 3 to 4% risk if one child is affected, and the risk increased to 10% if two siblings are affected. A few words about the hydranencephaly. In this, the cerebral hemispheres are absent and only the remnants of frontal, temporal, parietal lobes are present as sacs of membranes. Midbrain and brainstem are normal. Hydranencephaly, this is the disorder of brain growth in which the brain weight to volume ratio is greater than 98% or greater than 2 standard deviation about mean for age. For example, it occurs in Soto and Fragile X syndrome. Legencephaly is a defect of the neuronal migration and absence of brain convolutions. The brain has a smooth surface, giving appearance of a 3 to 4 month fetal brain. There is a 4-layered cortex instead of 6. Then holoprosencephaly is a defective formation of prosencephalon and forebrain structure like thalamus, hypothalamus, cerebrum, basal ganglia. Porencephaly is a cyst or cavities within the brain which are communicating with the ventricles or subarachnoid space. Thank you very much for your listening, and I will be looking forward for your feedbacks, and especially those candidates who go for the exams. I need your feedback, and if you succeed, your feedback is important, and if you learn, then your feedback is very important to help us learn more and to spread and guide the other people. Allah Hafiz.